Hi guys, so this is the review of the Innominate's anatomy before we get started for our video. So I just want to run through all the landmarks. So this is the pelvis right here. This is the anterior portion, and then this is the posterior portion. So to begin, we're going to talk about just the pubic bone over here. So we have a pubic tubercle anteriorly at the front, and that's what you guys are feeling when you're looking for the pubic shears. And then there's the pubic symphysis right here in the middle. And then down here we have the inferior pubic ramus and then the superior pubic ramus. And then this is a little bit more posterior, but this is the ischial tuberosity, which is also known as your sits bones in yoga. And this is what you were palpating whenever you were treating one of the pubic shears. You were monitoring at this bone. Here is the AIS. So that's the anterior inferior iliac spine, and then here's the ASIS, so the anterior superior iliac spine. And this is what you're evaluating when you're diagnosing the innominates. You're under the ASIS. And then I'm going to turn it around, and so on the inside, this is where the SI joint would be, so the sacroiliac joint that meets the sacrum. And then we have the PSIS right here, so the posterior superior iliac spine, and the PIIS right below down here. And then right here is the sacroiliac spine. And there's some important ligaments that go here, and this will be relevant in OBGYN when you guys get to that. So that's the basic anatomy of the pelvis, and then we obviously know the big bones like the ilium and the ischium is all this together, and they form the innominates. The end. So this is the hand movements to demonstrate the innominate dysfunctions. So my thumbs are representing the PSIS, my index finger is representing the ASIS, and then my middle fingers are representing the pubic symphysis / pubic tubercle. Okay, so I'm going to talk through each of the dysfunctions with you. So for an anteriorly rotated innominate, you're going to have, and we're going to say it's going to be on the right, so this side, I'm going to have my index finger down in the front and my thumb up in the back. So that's my PSIS is up and my ASIS is down. And we're going to have a positive standing flexion test on the right side. So that's an anteriorly rotated innominate. With that, you can also have a pubic finding. So I could have an inferior pubic shear. These are named as two separate dysfunctions though. So you would treat the inferior pubic shear first, which would bring it back up. Then you would treat the anteriorly rotated innominate. So you can also have a superior shear, a pubic shear with an anteriorly rotated innominate, but that's a more rare finding. Usually it's going to be an anteriorly rotated innominate with an inferior pubic shear if you have that finding. Now we're going to talk about posteriorly rotated innominate, so that's just the opposite. Your ASIS is going to be up in the front and PSIS is down in the back. So the PSIS is going to be low and the ASIS is going to be high. With that, you can also have a more common superior pubic shear. So it's going to be like this. Okay? Remember that those are two separate dysfunctions. The pubic shear is a dysfunction, and the posteriorly rotated innominate is a separate dysfunction. You're going to treat them separately. So you would treat the superior pubic shear first, and then you would treat the posteriorly rotated innominate. Now I'm going to talk about the innominate shears, which are different from the pubic shears. So an innominate shear superiorly is going to be just like this. Everything's going to be up high. The PSIS is going to be high and the ASIS is going to be high. And remember, I'm still talking about the right side being the positive side of the standing flexion test. You can also have an up shear like this with a pubic finding, okay? But remember, those are separate. You can also have an inferior innominate shear, which is going to be like this. The PSIS and the ASIS are both going to be low comparative to the opposite side. With that, you can also have an inferior pubic shear. Lastly, I'm going to talk about the outflares and inflares. So remember, you're using the landmark of the umbilicus, and you have to use your standing flexion test to lateralize. So with an outflare, that's in terms of the ASIS position. The ASIS is going to go out lateral, so it's going to be wide from the umbilicus compared to the other side, and the PSIS is going medial. Okay? So they would describe it as the ASIS being lateral and the PSIS medial for an outflare. For an inflare, on the other hand, you're going to have the ASIS medial, because we name it in terms of the ASIS, and the PSIS is going to be lateral compared to the other side. So that's out flared, so in flared.
For innominate treatments, the first thing we need to do is find the landmarks, the PSIS. They're going to be in a slightly different place for each person, especially male versus female. So this is the top of Katie's hips, and then I'm really just like, and hers happen to be right down here. Which if this was a guy, it might be more up here. Okay. So now I'm going to keep my fingers under the PSIS to make sure that it's down to the bone level, so that when she flexes forward, it's not fascia or muscle or something that moves up and gives me a false positive. And I'm also going to try, if I can reach, to grab her hips and pull them towards me, and then just so she doesn't fall. Would you please flex forward? And there's a lot more motion on the right side with that one. The reason there's more motion on the side that is stuck is because it's stuck to the sacrum. So instead of having motion at the joint, when she flexes, it moves forward. So with my fingers on the PSIS, I'm now trying to see the height difference. Sometimes I'm actually closing my eyes because I want to make sure that I'm not making it up. They don't look very different to me, but you may at times find they look like this, like one side's higher than the other, one side's lower than the other. I actually can feel that one side's more posterior than the other on this side. So that will help you in making your diagnosis. For now, I'm just going to say it actually feels a little bit, I'm going to exaggerate the motion, it feels a little bit like the right side is lower. So we've already evaluated the PSIS height and the standing flexion test. Now I'm going to have my patient lie down so I can do the ASIS heights. Could you please bend your knees and lift your bottom up and set it back down. And I'm going to grab their legs and pull them back down so they're not using their muscles and both feet come down at the same time. If they're ticklish, I'm very ticklish here, have them put their hands on their own body but down to their bone level, so not just sitting on their skin. Okay, and now I'm going to feel for the ASIS. You're going to go, I feel it here, so I'm going to slip under the ASIS and slight pressure upwards. And her right one is lower. Okay. Based on Katie's findings, we had a positive test on the right, so when she bent forward, my right thumb went up higher than the PSIS. Her PSIS and ASIS on the right were lower, and that tells me it's inferior innominate shear on the right rather than a superior innominate shear on the left. But her pubic bone was actually higher on the right, so her little pelvis looks like this. Okay, that's all the things. So first you're going to treat the pubic bone, and then we would treat the shear. So our dear Katie here has an inferior shear on the right side. We're going to treat the left side as though it's a superior shear. I'm going to grab her leg above the malleoli and move from midline, abduct, about 15 degrees. For her, it's really just her soft spot also. And then I'm going to internally rotate the leg, and that locks the hip in place. So instead of pulling at the hip joint, you can actually tell a difference between here, there's some give, and here it's a little more of a thunk. So now I'm really pulling more on the innominate than the hip, and that protects the hip and makes the treatment more effective. Okay. So as Katie breathes in, there's a lot of give that goes down as her diaphragm goes down. As she breathes out, I can feel the leg wanting to pull back up more, and I'm resisting that. Breathe in again, and I find my new barrier, and breathe out. And I believe Dr. Brown said 7 to 10 times. Now, we're not going to do HVLN. After your treatment, in order to reevaluate for effectiveness, I would have my patient reset their hips again. So bend your knees, please. And lift up and down. Okay. And then I can recheck the landmarks. A posteriorly rotated innominate is very similar for the doctor for a pubic up shear. So I'm going to have my patient scoot to the edge of the table. I'm going to stand here to hold her. I'm going to take the leg we're working on and drop it down and make sure it doesn't touch the floor. Hold her other side down with my hand. Okay? And the only reason it appears that there's abduction here is just so that her barrier is in the table. It's not because it's necessary for the treatment. And I'm going to put my hand above her knee or straighten your leg and below. But I'm more comfortable this way. And I'm going to have the patient push just straight upward into my hand. And relax, and find a new barrier, and repeat, and relax 3 to 5 times, and I'm going to pick up the patient's leg and put her back down. And scoot over. If the diagnosis, based on your landmark findings and flexion test, showed an anteriorly rotated innominate, the barrier would be posterior rotation, so that's where we're going to put the patient. And any way that you want to do this, if you want to do it this way, or this way, or this way, based on your size and the size of your patient. So we taught you guys to feel for the first tension. In previous years, there have been people who monitor for tension at the ASIS or the PSIS. It's a little harder to feel when they're lying down. When Dr. Weston did it, he found the same barrier each way. But I think, however you're comfortable is what you should be doing. Based on your lab, we just had you feel for the first tension, which is right about here for Katie. I'm just going to have her push into my thumbs, really, my hands. Relax. Second barrier. And again, push into my hand. And relax. And again. And relax. Passive stretch. And then I would set her leg back down. Okay. Bonus point. In real life, if you want to be using this in treatment and you're having difficulty with some of the pubic treatments we've shown you, you can take this anteriorly rotated innominate and move it into abduction, and that's going to gap the pubic symphysis. So now we can fix a down shear of the pubes with the same treatment. So now she's going to push into my hand here, and I'm going to find her second barrier. So to talk about inflares and outflares, for now we're just going to be doing the front view. This is your belly button, and if there was an inflare, this ASS would be closer. With an outflare, this ASS would be farther away from the belly button. So it's going to look like this or like this. Now in order to figure out if one side is inflared versus outflared, it would be the standing flexion test. So even though maybe I would think her left is the problem at the flexion test, as it was positive on the right, her right's outflared rather than her left being inflared. So if Katie had a positive standing flexion test on the left and the ASIS was farther away from her umbilicus on the left, this would be an outflare, which means her PSS would be closer to midline on the left as well. With an outflare, it may be difficult for your patient to get their foot across their leg. If their foot's like this when you try, or it kind of only gets, or toes can only touch, just put it on the same side. Okay? So I'm going to take my cephalad hand and find her PSIS and reach medially to it. Okay, so if this is her position of ease, because she's outflared, I'm going to put her into her barrier. I'm going to have her push into my hand here, which is her ease. At the same time, I'm going to be pulling her PSIS medial to lateral. Okay, so put you into your barrier and push into my hand. 1, 2, 3, relax. Again. 1, 2, 3, relax. Again. 1, 2, 3, relax. If Katie had a positive standing flexion test on the left, and the left ASIS was farther from midline or her umbilicus than the right side, and her PSIS in the back is closer to midline, so instead of her hips being like this, they're cocked like this, we really just want to shove them back in the other direction. We're going to do that with her leg and her PSIS. Okay? So if the patient has an outflare, they may be able to reach the other side, or they may stop about here. Right? So if their foot's here or here, just keep their foot on the same side. I think Katie can actually do this though. Okay. So my cephalad hand is going to find the PSIS. And if she's outflared, this would be her freedom. I'm going to push her midline to her barrier. I'm going to ask her to push back into my hand. 1, 2, 3, relax. And then I'm going to pull medial to lateral on her PSIS. And then push into my hand. 1, 2, 3, relax. Pull on the PSIS. Again. 1, 2, 3, relax. And pull. Okay. And then there's probably a passive stretch. There we go.
All right, so I've just seen the outflare treatment, and Elizabeth is now making me get on camera instead of being behind it all this time. I'm like, this is her revenge for a video that never made it to that was deleted immediately after it was shot. Yeah, see, you gotta bend the little laughs. So now then, we've done outflare. Let's just do inflare really quick. It's super easy. So we're gonna pretend that we're just gonna mess Katie up even more because we're doing all these treatments on her, right? So we've done an outflare, so let's treat this like with an inflare. So same deal with an inflare as with an outflare. If they can get their leg all the way across, which Katie can, and hold her foot flat on the table, you can do it that way. If they can't, you move it as close to this leg as you can get it and keep them to where their foot is flat on the table. But because Katie is actually flexible, we're just going to do it this way. So for an inflare treatment, freedom is going more midline with the knee or more in. Really, it's in the name. What I'm just going to do is I'm just going to find the barrier, and I'm stabilizing her hip over here because when I pull her leg, I don't want to actually pull it so that her hips rock. So I'm going to stabilize, I'm going to find the barrier, and then I'm just going to tell her to push up into my hand. Relax. Go again. And if you notice what her foot's doing, it's starting to lift off. So I'm actually going to move her to being over here so that her foot doesn't lift off. So then push again. Relax. Go again. Relax. And one more time. Relax. So she's still lifting off a little bit. So what I normally do in my actual hip treatment, that's a shotgun technique, this is your bonus, is I hold that foot down while I'm moving this. And that maintains that. But that's not part of this technique, and it's not going to be on your practical. So do it the way I did it the first time.
Cut.
K2 out.
So now we're going to evaluate the pubic bone heights. And so generally my fingers start somewhere around the belly button, like right, this is your belly button, yes. And I'm just going to take the palm of my hand and start pressing downwards lightly. Don't make them gasp. Okay. And now I've hit bone. Then I'm going to take my thumbs and place them on the bone. Or I can slide underneath the bone and kind of grip either side of it. I'm actually getting a better feeling for it this way. And it looks like the right one is a little bit higher. Or like I said before, you could be on top of the bone. To treat a pubic inferior shear, pubic down shear, I'm going to stand on the opposite side. You could probably do it from either side, but in class we mostly taught it from the opposite side. So we're going to assume that the flexion test was positive on Katie's left. Okay. Now, if your patient is significantly shorter limbed than you are, if you're a taller person, you can probably just put the knee in your armpit and then reach the table. It's clearly not going to work for me. This hand, regardless, is going to become your fulcrum underneath the ischium. Is that what you said? Mm-hmm. Okay. Yeah, ischium. Okay. Now, since I can't reach this, I'm really just going to have to slide down the leg farther until I can grab the table. And that does change my vector, so I really need to make sure I'm applying a down force and kind of wiggle around until I feel like my patient tells me it's, there we go. Okay. So I'm going to apply force straight down to the table and ask the patient to push straight up into my axilla and relax. And again. Relax. Is it still in your pubic area?
Mm-hmm. Yeah.
And again. And relax.
Yeah.
A modification would be to stand on the same side of the problem. So if the flexion test is positive on the right, you may want to stand on the same side. And now instead of being this way, I'm going to go around this way. And can't reach the table. I'm just going to grab onto the patient's hip bone. Okay. What am I grabbing onto?
That ischial tuberosity.
Probably the ischial tuberosity. Okay. And you are going to have to still create a fulcrum with your hand underneath the ischial tuberosity. I meant with this hand.
Oh, okay.
This one's a fulcrum. I was like, there's no way.
Okay.
So now that I've got, the patient is now my table. Push up into my armpit and relax. And I'm going to ask my patient, where are you feeling that?
Oh, just
That wincing in
that
your
hip.
How about now?
That's better.
Okay. Push straight up and relax. And again. and relax. If when you're palpating for the pubic bone, the patient has some tenderness there, but you don't notice that one side is higher than the other or inflared or outflared, they may have a compression or a gapping at the pubic symphysis. You're not going to be able to know which one it is, so we're just going to go ahead and treat both. So this would create a gapping if it was compressed, but you don't know. So go ahead and keep the patient's feet together. I'm going to have them squeeze my hand, squeeze as hard as you can, relax. Again, squeeze, 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 and relax. And again, squeeze, and relax. Then we're going to go the opposite way. So push in, no, that's what we just did. Push outwards, and relax. Out again, and relax. You might be doing it this way. Push out again, and relax.